Good morning and welcome everyone to Hope from the Heart of Texas, a multidisciplinary model for staff care during the pandemic. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. Some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions at any time to our panel by typing your questions into the questions pane in that same control panel. You may send in your questions at any time. We'll collect these and we hope to address them in our Q&A at the end. I often get the question that a link to the recording will be sent to you automatically, probably about a day after the close of the event. And with that, I'd like to introduce Jeannie Werpsa, Research Chaplain, Department of Spiritual Care and Education, and the Program Manager and Clinical Ethicist with the Ethics Program at Northwestern Memorial Hospital. Jeannie?
Hi, welcome everybody. I see I have a little sunshine coming in my window. Hopefully the rest of you guys do as well. I'm here from Chicago and really thrilled to welcome our colleagues from Dallas, the heart of Texas. Today, we will be in some ways following up on a webinar that we did last week, where we were again looking at different ways in which we as chaplains can support our team members. And while that discussion last week was confined to kind of what chaplains are doing by themselves, you'll discover in today's webinar a very different model, a model of collaboration. And again, I won't say much more about it because I will let my colleagues talk about that. Next slide, please, Andrew. So just a quick overview. We will be allowing our colleagues from Texas to tee up and kind of show you this model that they've developed. And then we will spend some time speaking with them about different components of that program. And then, as Andrew mentioned, there will be time at the end to respond to the questions that you've hopefully put in your questions function. Next slide, please. And without further ado, our panelists today are the Reverend Cesar Rentie, who is Vice President of Pastoral Care at the Methodist Health System, Reverend Elias Lopez, who's the Director of Pastoral Services. Welcome. And then Kathy Ross, who is the Director of Wellness. And again, without further ado, next slide, we'll let Cesar and our colleagues begin their presentation.
Well, Jeannie, thank you for the opportunity to be here today and to present the work that we've been doing as Pastoral Care Department and working in collaboration with the different colleagues that we have throughout our system to take care of our patients or our staff during this time. I also want to take the time to thank my colleagues, Kathy Ross, who is the Director of Wellness for Methodist Health System, and Reverend Dr. Elias Lopez, the Director of Pastoral Services for Methodist Health System, in all of the work that we have done together in their leadership in helping us do this. Before I get started, I'm always learning that you're from Chicago. I played for the Bears, got drafted by the Bears, so understand that. I'm a recovering athlete. I always say my body always reminds me every morning I get up. I make noises that I used to didn't make, so I'm constantly reminded of that. Well, as we reflect and think about this time that we're in, it has been, I remember and recall a conversation that I had with a friend talking about when events happen in your life and when disruptions happen. It's important to discern whether that experience will be for a short period of time or a long period of time, and then think about how you're going to live through that time. And what he said to me, I think, really shed a lot of light on kind of thinking about where we are. He says you either have to think about it as a snow day or a blizzard or it's an ice age. And as I think about this pandemic, I think of it in terms of an ice age. As we think about the headlines and all that we've read and seen and experienced as chaplains, we are in an ice age. And I feel, you know, from everything that I've known and seen and have experienced and heard, not only from my colleagues, but from other folks in different systems, that this pandemic has changed healthcare for the long term. We are in an ice age. You can go to the next slide. In light of that, Methodist Health System, we're located in Dallas, Texas, or I would say North Texas area in the DFW area. We have 6 hospitals in our system and medical group, and then clinics and other areas. We have about 10,000 employees in the healthcare system. And so as Methodist Health System shares the name with Methodist Church, it was started here 95 years ago by the Methodist Church. And then as Methodist grew, it separated from the church while still connected to the United Methodist Church. It has its own board, its board of governance, and its way of operation as a hospital within the Metroplex. And so it shares a covenant relationship with the North Texas Conference of the United Methodist Church, but its whole entity and business model and what it does is to care for the folks and the people that live here in our area. And these are the hospitals in our system. You can go to the next slide. Our mission and vision for Methodist Health System is to improve and save lives through compassionate quality healthcare. And then our vision is to be the trusted choice for health and wellness. And I'm sharing this with you because this really is something that has framed how I have seen our work as chaplains in the institution. And so when I became the leader of our department, I really wanted us to spend some time thinking about who we were as a pastoral care department, understanding who Methodist Health System is as an entity, and then how do we take our skill set, what we do, particularly as chaplains, and help Methodist Health System become the trusted choice of health and wellness in Methodist Health System, and then how do we help Methodist in its own mission to provide compassionate quality health care and what we do. And so with that being done, we came up with, my colleagues in our department came up with a mission statement to provide a ministry of compassion and healing to all people of Methodist Health System through faithful pastoral ministry or pastoral services. And what that helped me do as a leader is really frame and understand how it is then we should see our department and how we should see ourselves at work in Methodist. You can go to the next slide. And so these are the leaders in our department and the way our department is structured. And so as I started thinking about it, I started thinking about how then do we accomplish this mission of helping Methodist do the work that it's doing in terms of providing compassionate quality healthcare, and then how do we move that mission forward as a department. And so I sought to have leaders across our campuses in each one of the hospital systems. We have 6 hospitals. We just acquired a new hospital, so we'll have another leader that will be at the other hospital. So that's a new one. But this is an old slide that kind of reflects our model and kind of a system approach that we really took in terms of connecting to the system. You can go to the next slide. So as I thought about our system approach, I also thought about who we are as a department and the people that we want to touch with Methodist Health System. So obviously the first one is our patients. And so when we think about touching our patients' lives, what is it that we're doing and how do we care for our patients? So we thought about the different offerings that we have as a department and what we would do. I mean, there's all the standard stuff that we do, but then we talked about advanced care planning, how we could help our hospital and connecting with our patients and families and helping and empowering them to be able to make the best decisions possible that they could make. And Dr. Lopez and a few and another one of our chaplains, we got them to be train the trainers in this so that we can continue to educate our staff. And those are some of the offerings that we talked about. Then we talked about some of the offerings that we wanted to present to our staff. And so we talked about a critical incident stress management. So these were some of the things that we were doing as a department, thinking about training our chaplains and doing this type of work. We thought about, we're doing that type of work with critical incident stress management and all the ways in which we touch our staff, Hope Group, to connect with them in that way. And then through the community is through our faith community nursing program. And that was how we are oriented and to think as a department, and how I always encouraged us to think across the system how we needed to connect with these three entities. So you can go to the next slide. So as I thought about that, and as I thought about how we would connect with all of these three entities, and as I continue to think about that, I think about that in light of where we are today and the pandemic. And of course, it has disrupted a lot of what we've done. And as I shared earlier, we are in an ice age. And I think what's really important for us to know and to really understand is that these numbers are reflective of massive disruption in healthcare. And I know that we're all experiencing it, but what we need to know is that that disruption is not going away. When you start looking at $24 billion of additional labor costs incurred by hospitals compared to where we were, you know that at some point that bill will come due. That bill will come due, and we need to be, we as pastoral care departments, we should really be aware of this and figure out where we are in the institution and how we provide the best care possible to help with this situation. And then I think also, as you look at this is also a sign of the stress that we're all experiencing in the system. You can go to the next slide. And this stress is experienced by our employees. The main resource in providing care, to the people that come to our institutions and come to our hospitals are our employees. We spend lots of money on equipment and hardware and all of that stuff, but it is the people that do the day-to-day work. It's the housekeeper, coming in and taking out the trash. It's the person that's bringing and delivering the meals. It's the nurse that is on the floor in the COVID unit, an ICU unit, and all of those different ways in which they are working. It is impacting the administrators and all of the folks that are doing this. And we are all experiencing this because we are working with less, we're working more, and we're working in a different way than in the way that we used to work. I think we had a death here in our hospital. This is kind of how things have changed, where it's one couple dies, or they both are dying, and there's no family around. We have to think where we used to be, where there was family around to provide support during these times. There was no one around, and it's just the staff there. This type of work is now producing that kind of stress on our staff, and we're doing it with less people. I think one of the things that I know that in the DFW area, and I know it's across the system, is that there's just shortages in nursing. We're not the only hospital that's experiencing it. A lot of hospitals are, But when you think about that shortage, and then you go back and you start thinking about the number of confirmed cases, we're in the middle of an ice age and it's only getting colder. And so we have to figure out how we're going to take care of our staff during this time. You can go to the next slide. I love Eric Hoffer's statement and what he says: in times of change, the learners inherit the earth, while the learned find themselves beautifully equipped to deal with a world that no longer exists. I think if you think about ice ages, there have been a few animals that have survived ice ages, and I think of two of them that have probably been pretty successful: cockroaches and alligators. I mean, for some reason, you know, they seem to be pretty successful, and they figure out how to get through these things. And I think for us as spiritual caregivers, we have to become learners in the midst of this ice age, and it is learning while we're moving along and doing what we're doing, that we're constantly open to this world to change. And as I said, we're not going back to where we used to be. We're in a whole different age, and I think it's important for us to know that. And it's important for us, as if we are going to give the care and touch the lives and support the people that we work with, that we become learners, that we're constantly learning in this new world, so that we're beautifully equipped to care for those we encounter every day. You can go to the next slide. So one of the ways in which we did this, when I got news that there was a virus, and it was early on, we all got the same news. There was a virus, and we heard about that virus, and then I started doing some reading around it, and then of course I watched on the East Coast get hit. And I watched those numbers rise, and I listened to the briefings that were done every day with the governor in New York. And I allowed that opportunity to really inform how I felt like our department needed to get ready for this. Because I said, if it's happening in New York and they're getting hit at this rate, then I know eventually it's going to come to Texas. And so internally, we started having these discussions about how we were going to respond to it. We were really trying to get ahead of it. We had some of the pieces in place and started thinking about how we would respond as a department and what we wanted to do. One of my major concerns was moral injury. While I know there were lots of things that we experience in the hospital, my major concern was the moral injury that we would experience if this virus was hit the same way that it did in New York. And so I reached out to different leaders in the community who understood and knew moral injury, and started to really get a lot more information about that and how it would impact our staff. And as I started, and as the numbers started to rise, and as Texas went to sheltering in place, we were really kind of in position to then begin this discussion about how we could support our staff. And so one of the things that we did was I went to our foundation and I asked for money, because we went to sheltering in place. It meant that we had a whole nother way of operating. So I went and asked for about $50,000 so that I could use it to get iPads into our chaplains' hands, so I could use it to do all these different things, so we could continue to connect and keep families connected to their loved ones at very meaningful times, and be able to communicate with them, not just over the phone, but face to face. And so we asked for all of these different things, and being able to do that. I was granted that money and allowed to spend it. And then at that time, while we were in the middle of that transition, and doing this kind of work, there was this outreach from other parts of our organization to connect. And so through organizational effectiveness, we connected, and then Kathy's wellness team, we all connected and started having this conversation about what's the best way in which we could support our staff. You can go to the next slide. So I started thinking about each one of our organization or departments and how we're structured. And what was really important for us is that we all have some sort of system responsibility and connection. And so for the pastoral care department, looking at the three entities that I showed earlier, the three ways that we connect to patients, to staff, and to the community, kind of is reflected in the way that we are structured within our org chart. You can go to the next slide. And then wellness was the same way. The way that they're structured and the way they have system responsibility, it only made sense that we would have a collaboration with them. And so as we started thinking as a department, we knew that we were limited in our ability to be able to connect with everybody in the institution. And so Kathy and her team, they were able to, they also have system responsibility, and we saw there was a way for us to work together and working together as a team to be able to do that. You can go to the next slide. Then, I'll stop for a minute and let Kathy talk a little bit about her thoughts about this. And I'll let her talk a little bit about this and how this relates to what we do as a system.
Yeah, so Empower, a higher level of well-being, is our wellness brand. And we just came into this brand early 2021. We left a legacy brand of Live Well, Shine Bright that's over 10 or 12 years old. And in reevaluating all of this, we realized not every employee can live well and shine bright. So what would be more realistic would be something that we were trying to achieve with a relationship with the employees. And we created this wellness wheel so that it encompasses more of a holistic, whole person well-being concept. Historically, we had been very outcomes driven, know your risk factors, incentivized based on your outcomes, but now we've stepped back and we're taking a whole person approach. And if you see the little puzzle piece of purpose there, that's where the spiritual piece comes in. And in everything we do, we look at how we can meet all of these puzzle pieces for each employee.
Thank you.
Next slide.
Yeah. You can go to the next slide. So the other part of the organization was the MAP2, and this is the Accountable Care Organization, and they also have touch points with our employees as well, and the social workers work with our employees, and so this was also another opportunity for us to really broaden our reach and continue to work together as a group. You can go to the next slide. And then the last one is organizational effectiveness. And organizational effectiveness is really a department within our organization that is responsible for education and all of this. And so they have Methodist University and online platforms in which we would be able to connect with a lot of our employees and helping us be able to normalize and talk about what it is that we're experiencing and continue to educate our staff about all of the different types of stressors that we were experiencing. Obviously, talking about post-traumatic stress, talking about moral injury, talking about ambiguous loss, and how all of that is encompassed in the areas where we're working and how that's making an impact on us. And so using organizational effectiveness in this way was allowing and allows us to be able to do that. You can go to the next slide. So when we came together, we started really thinking about it and where is the infrastructure, and then how do we connect all of these moving pieces and parts, because we all have system responsibility, but we all have different missions, for lack of a better term, or goals that we're accomplishing based on our skill set. So when we all came together, we really sat down, and I remember saying, we need a handle. We need something to be able to say to our employees that they would be able to grab onto. And so I wish I was smart enough to come up with this concept, and I'm not sure who did, but we came up with MHS Cares, and it really aligns with our internal message that we have to our staff, which is to take care of Methodists, take care of each other, take care of our patients, and then take care of ourselves individually. And so we saw this as part of that. And so as we started thinking about our functions and what we do as a department, and then in each one of us, and how we would work together, we placed ourselves in a collaborative under the umbrella of MHS Cares. And so we created really two groups, one specifically for frontline staff that were, that worked that work in Methodist Health System. Not that all these people don't, but that they're housekeepers, nursing, physical therapy, different departments. So we had one that was strictly designed for kind of our hospital approach. And then we reached out to our physician, who is responsible for wellness, who also has a system-wide approach. And then we also contract with an outside organization to work with this physician. And so we created another arm that was called MHS Cares for Docs. And so this was really our opportunity to have something that would be designed for physicians. And so there were two different platforms, one speaking to our physician group specifically, and then one speaking to Methodists, for lack of a better term, general employees, but that would speak specifically to them, because the needs were so different. For physicians who have offices and who have employees that report to them, they needed to talk about, how do we, we're having to shut our office down. We're not getting the same type of income. How do then we take advantage of the offerings that the government gives to us? And so there were webinars and seminars that were done specifically for that and for physicians, and they continue to run under that umbrella and with that group. And the person who works with Dr. Lansdowne, it was actually a chaplain within our organization that then left and graduated out of our CPE program, went on and did some other things, and then sat as a board member on our state board of TPAP, and then came back with all sorts of resources. And so we collaborated with him as the pastoral care department, using the funds that we had been given to help then put a model in place to help support Dr. Lansdowne and our physician group with an MHS Cares for Docs. You can go to the next slide. So our mission is to support the mental and physical, spiritual well-being of our staffs during the COVID-19 pandemic, to really serve as an intermediate and emotional, provide intermediate emotional support to our staff when sentinel events happen. And so when something happens, that we wanted to be able to provide our staff with that type of support, then to provide education about various mental health conditions and the symptoms of stress. So thinking about what those were, and then trying to normalize it in a way that we were saying it's okay if we feel stress. It's okay to be human at this time. It's okay to ask for help. And so thinking about how this pandemic was impacting us, particularly in the early days when we went into sheltering in place and when people were exposed, literally put on isolation, my concern was that they were there without that support. And then the other thing that we thought about was, to assist our staff with finding specialized services and resources beyond the team and peers' scope and expertise. The best example that I have is a nurse who had a granddaughter who was struggling with who was having a mental wellness episode, and so she was wanting to find a counselor for her, but her granddaughter wasn't under her insurance, so she couldn't just go to EPA and direct her there and get her the support she needed. So what we were able to do was look at the resources that we had, found a search engine that we use. At the time, it's a search engine that finds low to free cost services, and so we went, found a zip code where she was, looked through there, found a counselor, connected her granddaughter with the counselor free so that she wouldn't have to worry about that. And that all happened within the MHS Cares umbrella. And so this was some of the things that we did as a team. Go to the next slide. So out of that, we started thinking about all the ways in which we wanted to provide service and how we would do that. And so the MHS Cares Kit was really something that came out of faith community nursing. Our faith community nurses started working because we started sheltering in place while they had some responsibility of connecting with the community. We brought them internally, and so they started working with our employee health. And what came out of that was that we were having employees who were being exposed to the coronavirus and being sent home on isolation. And our faith community nurse talked about, hey, we need to develop a care kit. And so we put a thermometer in there, we put a face mask in there. We went and Kathy was very generous with us in putting some of the armbands. There were armbands, exercise bands that were put in there. There were the adult coloring books that were put in there. And then we also just put a message in there that came from our department that just said that, we want to be a support to you, and then try to continue to reach out to our staff that were on isolation. The other thing is, out of this, we started a support group. And this was really initially when we knew that a lot of our staff was being sent home. And my concern was that, yeah, there's nothing more anxious when you get disrupted and then you get sent home. And at Methodist, we didn't just lay people off. When we had to shelter in place, people went home, but they went home with 70% less pay, 20% less of their pay. And so I knew that was producing, it would produce a lot of anxiety for folks if they didn't have that income. And if they had someone else who had lost a job, it's like you lose all of this stuff. And so it's like, how do we provide the support? And so we would provide the support groups, which we use this platform, Zoom, to be able to do that. And we met it was every Wednesday night, I think, we started meeting and inviting our staff to just come and have a place where they could connect. We did the same thing with MHS Cares. And then we started using the Zoominars, or I call them Zoominars instead of webinars, but Zoominars to really reach out to our staff to then start talking about what it is that we were experiencing. Out of that grew T-carts, and we partner with wellness and pastoral care, going out to the floors. And then I'll let Elias talk a little bit about the critical incident stress management and some of the other things that we started to do.
Thank you, Caesar, the opportunity to be here. The critical incident stress management is the CISM program that is a peer collaboration that takes place to help people going through critical incidences. And what we realize is the pandemic is a critical incident. Everything is a critical incident. So we started becoming more intentional about going to the units with CISM. All the chaplains had been CISM trained, and there's a lot of different personnel within the health system that were also CISM trained, nurses, social workers, different roles that are within the system. But we wanted to offer a peer support where we can gather with employees, with staff, so they can process what's been taking place, diffuse and debrief what's been happening, because it was not just troubling what was happening on the floor, but what was happening in their families, what was happening at home, and the distance and being and feeling like they were ill prepared to care for patients here, but also ill prepared to care for family and what they were going through. So critical incident stress management became a really powerful tool for us to hold that space within the different units and tap into the different roles and functions that had been CISM trying to facilitate that conversation. That was really helpful. The MHS Cares cart is something that developed out of the community responding with open hearts and wanting to provide for the staff. They would flood our department with snacks, with cards, with stuff that they wanted to give to employees. So we would start and we would collect these things through the pastoral care department and take them to the units. As we started to really talk about this in the collaboration of MHS Cares, we thought there's a better way for us not just to take them snacks, but to also be able to share with staff all the resources that are available to them. And that's when wellness started joining us, and we started collaborating on the different staff support initiatives that the system already had in place, so that we can go and present them to staff. So we're not just taking the snack, we're not just taking the gifts that the community brought, but we're giving them also access to the resources. We're going to them, and that became very helpful and very favorable for the staff to feel that the system was caring for them and that we were reaching out to them. I think that's
okay. You can go to the next slide. So one of the things that we also try to do is normalize what we were doing, to have different content experts come and present on our webinars. And as I shared with you, we had tons of speakers come and speak on our Zoominars. And so we would, we'd find guest speakers or the collaboration, the MHS Cares group would come together, and we would have subject matters on different topics come and present. And then wellness came up with a half hour to empower, and it was Kathy's concept, and to really, rather than have a 1 hour lunchtime where we would do the Zoom, it was a 30-minute. And Kathy, do you want to talk a little bit about that?
Yeah, I mean, obviously we try to hit every single staff, and when you have 24/7 staff working 12-hour shifts, patient care, but then there's other employees that are desk workers and do administrative type work. We try to cover the whole gamut. So reducing these Zoominars to 30 minutes to try to capture just another crowd that can't make it to our hour sessions. Knowing though that every single topic, every single presentation is recorded, so they can go back to our Methodist University and watch it at any point in time.
You can go to the next slide. And these were some of our guest speakers that we invited to be a part of the Zoominars. Because I played at the University of Oklahoma, the very first person I reached out to really just kind of, heighten awareness was reach out to Barry Switzer, former head coach for the University of Oklahoma and the Dallas Cowboys, to really talk about his story of resilience. Both of his parents, his dad was murdered and his mother committed suicide. And we talked about it in terms of how do you overcome something like that and live a life of resilience. So all of these subjects, we had Dr. Sexton come and talk about gratitude, 3 good things, shared with our staff, his website and how 3 good things and gratitude is a way to really kind of shift how we look at and our brains function. We had Dr. Ramsey from the Soul Repair Center come and talk about moral injury, and do a presentation on post-traumatic stress, and to really present how this is playing itself out in healthcare. And then by that time, George Floyd was murdered. There was a huge response within the system itself. We invited Patrick LeBlanc to come and talk about racism and mental health. And so we tried to cover all of these subjects and tried to have different ways in which we would connect, but to normalize what it is that we're feeling and to continue to educate our staff about what it is that they're feeling. And you can go to the next slide. And in conjunction with that, we have brochures that are on the T carts that that are in our that's in employee health, and that we try to get this information out to all of our staff. You can go to the next slide. And this is just another example of that brochure, which is a critical incident stress management brochure, and it just talks about the different responses and reactions. So just to continue to educate our staff on it. So when the T-cart goes out, all of this information goes out with it, and it's handed out. You can go to the next slide. Hope Group, and that's just more information about how we get that information out. And Hope Group is really the work that Daniel does in our staff that struggles with chemical dependency or all of that stuff. And so I think it's important for us to note that if the numbers exist in general public with addiction, that they'll exist in the hospital. And so we need to be able to have a way for people to access this help without feeling shamed or threatened that their job or reputation would be damaged. You can go to the next slide. I love this quote by Dr. Martin Luther King, where he says, "We're caught in an inescapable web of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all of us indirectly." This pandemic has impacted all of us. And none of us are in a silo. And I always say that this virus has informed us that we're in this together. And the only way for us to solve it is together. So thank you.
Thank you. Next slide, please, Andrew. So we are going to now engage with our panelists for some questions. A couple of them I think you may have already answered. I know we're a little short on time, but I really want to thank you. I am just impressed with the comprehensiveness, the system level of this more than anything. Next slide, please. And some of the creative approaches, may I just say. Really stunning, just stunningly creative approaches. I love the sending the nurses to staff who were isolated at home. Like, wow, what an incredible idea. So you may have already addressed this, but I thought I would ask just for a few minutes if you could lift up what is actually unique about this, because lots of our spiritual care departments and healthcare institutions have recognized this need to better support staff as a result of this pandemic and increase their attention on this. What makes your program unique? Why would people want to potentially emulate it? What counts for its success?
Elias?
Sorry, I was muted. I think the collaboration was really helpful. When the pandemic started, there was a sense throughout the system that everyone wanted to do something. We all wanted to do something. We all wanted to try to provide some support in some way, but coming together with the different disciplines and really having an open dialogue of what we could do together versus independently or in isolation. We all had a sense within our own roles, some of the tasks that we could perform, but the collaboration when we held it together was really inviting people to think of new programs that we could put together through our skill sets, not just our tasks. What can we do that will bring everyone together? So when we started thinking about the support groups that we started putting on there, we didn't have support group just at one time. We had it at 6 different times throughout the week, and the different groups, the different collaborations, and the collaboration, excuse me, from the different disciplines, we created a schedule where we rotated, and there was different voices that were present there to be able to offer from our different skill sets the things that we could do. The CISM, the critical incident stress management collaboration, we pulled from different disciplines, we pulled from different roles, and that allowed us to be more open and involved in all of the staff and wherever they were, right? That helped us connect with EVS, that helped us connect with the doctors, it helped us connect with the different units within the hospital, with pharmacists, with people that we don't traditionally see at the bedside. It allowed us to do that. So the collaboration, I think, was really powerful, where from our individual perspectives, we saw some of the needs, and then we thought together, here's the skills that we bring together, what can we develop? And from that came a lot of the work that you saw.
I wanted to add too, with the T cards where the chaplain and the wellness coaches have set times where they go to various units on all the campuses. That's proactive. That's us reaching out, going to them, going where they work, into their break rooms, taking the card around the unit, rather than waiting for someone to call us that they've had a critical incident or they need us. I mean, we'll always take anyone to call us, but we want to reach out and be proactive.
Thank you, Kathy.
And I think to Kathy's point, I mean, I think it's just kind of the way that we were oriented in the department, thinking about that mission and reaching out. And so it was congruent. We just really worked together in saying, how then do we support it and how do we make that happen? I think the other thing is that while we house it, while we I would say kind of use our infrastructure to support it, what we do is we make that access available. So reaching out to all of the folks that we collaborate with and making sure that, you know, this is available to them. So the T-cart, while it sits in the pastoral care department and we work on, you know, trying to get it out on the floors, it is a true collaboration in that the wellness coaches and the pastoral care, the chaplains are all going out on the floors together and making sure that the information is getting out to folks.
Yeah. One of the things you said earlier struck me, Cesar, which is this, it's the people didn't experience it just as pastoral care caring for you, but it's the institution actually cares. There was something about raising it to that level of this is Methodist Health System funding this, organizing it from, you know, again, it came from bottom up, but it wound up being, again, this umbrella. I mean, how do we help our staff really appreciate that our institution cares for them, not just me, the chaplain, or you, the wellness coach, because that's your job. Really kind of bumped it up to that level. So
yeah, you know, I think for me, I started looking at the mission. I looked at what, you know, our internal stuff, you know, what we wanted to do internally. So having that information really helped me to be able to communicate up. And then, you know, obviously with my colleagues who they're communicating with folks that report to them, and then how we bring all of that together. And so it was like, how do we integrate and take all of that and let our staff know that we care and that we are here and that we want to connect them to the support that they need. So they're not out there alone, but they know that they can have that support. And so I mean, the very fact of or the need to move and to act really came out of that mission to provide, you know, a care ministry to all people of Methodist Health System. So thinking about how I do that as a leader, and then, you know, connecting with all the other folks that have different motivations and goals, saying, hey, how can we help and how can we do that together, and then always communicating up.
Yeah. Can you jump down to the third question, Andrew? I think we've talked a little bit about that. So what did you see and how did you measure effectiveness or success? And this is sponsored by Transforming Chaplaincy, which is a research arm. So I guess I'm wondering too, like, again, what are the metrics? How do you know that it made the difference? One of the questions that's been posted is it just by counting how many touches you had? Are there other, again, kind of metrics, ways of measuring success?
I'll let Kathy answer that question.
Well, obviously, number of touches is important to us because we want to know that people are at least interested and that the topics are relevant to what's going on. But recently, it was just this last spring, we had an engagement survey for all employees, and it was through Pressgini. There's several questions that are answered. One in particular, actually a couple of them are related to resiliency. And so we scored a 4.31 on a scale of 1 to 5, and this turned out to be 15% higher than what Pressgini's normal healthcare organizations have, their national groups. And resiliency is the ability to recover and bounce back after adversity. So our employees feel like they have that given to them from their employer. Now, it could be other things related to benefits too, but because this was instituted in 2020, we feel like that's definitely a reflection, and senior leadership has given this as a result of MHS Cares.
Directly attributing that bump in score, right? Which I think, honestly, most of our institutions probably suffered a drop. A huge drop, in fact, because of the pandemic. Interesting. Yeah.
And then, MHS Cares is not just a one-time snapshot. This is all we're doing. We're expanding and growing. We're going to be adding ambassadors onto each campus. And with that, and starting our pilot program, we're meeting with our actual clinical research team so that we can model it and have a true measurement of effectiveness, whether that's through, focus groups before and after. And they're going to guide us so that we set it up for measurement. Because MHS Cares has been going on just about a year and a half now, and we put it together quickly and said we had to jump in and do it. And then it's like, yeah, how do we measure it? We want to make sure we are effective.
Yeah, and go ahead, Elias.
I just wanted to add what Kathy was saying. So when we were collaborating and we were talking, we were very clear about one thing. We weren't trying to replace anything that the system already had in place. We knew that the system had developed EAP, had developed different types of resources for staff. We just saw that there was a gap. That's what we identified in our collaboration. Employees were working at the bedside, and there was a gap from them accessing the actual resources that were in place. So we wanted to be intentional about standing in that gap. And that's what I think we did really well as MHS Cares. In going to them, as Kathy identified, we went to them and we gave them the resources. We put them in their hands. In some instances, made the call for them. So that they would be able to contact. So I think the employee engagement score about resiliency, as Kathy points out, speaks to that. We filled in the gap, not by replacing, but being intentional about making sure that they knew that these resources were available and that as the intermediary, we were able to connect them with. So I thought that was really.
Yeah, and I think like one example, we had the Ben Fund. And folks our Ben Fund is really all of our employees giving, they give, like 30 minutes to this fund. So like you can give a certain amount of your time and salary to this. And so we had a lot of money that was in that fund. And so we dispersed a lot of that money too from that Ben Fund. But the education about the Ben Fund and getting access up came through MHS Cares. So it was really that bridge. It was the bridge of really just kind of connecting people to the resources that were there.
Fabulous. We have just a few minutes left. I think you've answered most of the questions. I want to jump down to the very last question. You've talked a little bit about plans for sustainability, but I really want you to end by talking about I'm thinking mostly on the line you have managers, heads of spiritual care departments, leaders in institutions, maybe some wellness folks. How would you describe the benefits of engaging in this kind of collaborative effort for spiritual care departments? They're stretched thin these days, right? They're having to prioritize where you're going to put your resources. So how are you going to tell them this is worth it for them as a spiritual care department?
I mean, I think you talked about it, that spiritual care departments are stretched thin. I think traditionally, you know, they're small departments within the system. They're a cost center. I mean, we're a true cost center, and so you know, it's really thinking about, you know, how do you collaborate with people who have the same motivation in terms of care. While we're doing spiritual care, Kathy is doing wellness, and she's doing other, you know, other things to support staff. And while she may have some a spiritual care component that would be connected to wellness, we saw it as this is a way for us to really broaden our reach and build community and connection with our colleagues to then touch all of the folks around us. And the other thing is that not everyone wants a chaplain. And so, you know, as I was thinking about it, it's like, you know, if we can, if somebody connects better to a wellness coach than a chaplain, then it helps the institution. And so I think, and it helps the employee. And so I think having this collaboration really benefits spiritual care in this way. I think it also benefits wellness as well. You know, we do a lot of work of just kind of maintaining and holding all of the stuff. And it allows wellness to be able to get out and you know, and we partner in that way. And so I think it's in that sense. And I think in terms of sustainability, you know, when Kathy talked about the ambassador, it's about educating our staff, but really finding a person who's not a leader, not a manager, but they may be a leader in the department and have influence, recruiting that person, educating that person in CISM, educating them with mental health first aid, educating them about all of the resources that are available, and then connecting them to MHS Cares, and then connecting them to this. The other thing that Elias and that we talked about was developing really a tool where we use existing resources. So we have SurveyMonkey. How do we do a QR code, develop some questions, and then on the fly, when the T-cart shows up, do a QR code and then do a survey so we can get instant feedback. So some of the things that we're developing and looking to do in the future.
Well, we will keep abreast of your successes and your ongoing development. I just will say, for one, as a person who's long time been concerned about our staff well-being, I so appreciate what you're doing, and I will echo what George Fichette has just added to the comments, which is how inspiring this is. And I mean, I think it's just novel. So hopefully folks will pick it up, and if they can't replicate the whole kit and caboodle, at least take some small ideas from you today. I want to just thank you. I know folks can't take themselves off of mute and clap for you, but I will do that on behalf of everyone. And thanks to Transforming Chaplaincy for hosting us today. Stay in touch, be well, be safe. And here's to the end of the pandemic, or at least again, in the next wave of whatever comes our way, to having more resources, more hope, more strength, to work together to thrive and not just survive. Thank you.
Thank you.
Thanks, everybody.
All right.
Andrew?
Ma'am?
Oh, yeah, if you want to send out,
Uh-oh,
is he still there?
something happened. And maybe he'll come back.